and I'll be moderating this session. And how we're going to do it is we'll have the first panel folks come up, and then once the discussion is done and the Q&A, we'll have the second group come up. So that would include those people who have posters for 1, 2, I guess is not here, 3, 4, and 5. If you could come up to the stage and sit at the table, it'll just save time going forward. Yeah, come on up.
Let's see, we have Dr. Zhang is for 2 of them.
Where's Dr. Zhang?
Dr. Griguolo. Let's see.
So Dr. Griguolo and Dr. Zhang.
Dr. Brenner's here, so
Yeah.
he's one of them.
Yep.
And then I think that may be it.
Okay, so what are we missing?
So Dr. Zhang is representing 2 of the posters.
Right.
Yeah.
But is he here? Yeah. Okay. All right. Good. We're good to go. So to start us out, hopefully everybody had an opportunity to scan the posters and get a sense of what they're about. But to put things in perspective, we're going to have somebody who's well known to this crowd and in this discipline, Carey from Duke University, discuss them and put them in perspective. Carey?
Excellent. Good morning, everyone. It's such a pleasure to be here this morning to talk on the topic of, let's see, we'll try the mouse. There we go. Great. To talk on the topic of clinical care in our patients with brain metastasis. Just a brief disclosure slide. Great. So I think this audience knows that brain metastasis arising from breast cancer are a significant clinical challenge, increasingly common in our patients with advanced breast cancer. Around half of our patients with advanced triple-negative breast cancer will develop a CNS recurrence, and 30% with HER2-positive disease. You'll see here a schematic of the blood-brain barrier, or often termed the blood-tumor barrier, in the setting of brain metastasis, which can present challenges in terms of trying to deliver cytotoxics to the CNS. And then luckily, we've seen a shift in the tide over the past decade, but historically, our patients with brain metastasis have been excluded from clinical trials, which has been a challenge in the development of novel compounds. But I think after today, you'll see we really are seeing changes here. So here are some of the radiographic characteristics of presentation of brain metastasis. Some of our patients present with a solitary large lesion. You'll see depicted in your top left. And then we still do see patients with multiple lesions, which may or may not be associated with hemorrhage. On the right-hand side of the slide, you'll see leptomeningeal disease, which we really have classified now as more nodular dural-based disease, as well as what we see as our traditional leptomeningeal disease, which involves the sugar coating of the cerebellar folia, which you see here in the bottom right. So in thinking of local therapy for brain metastasis, this is a simplified algorithm for the way we think about treating our patients in the clinic. When patients present with a solitary lesion, we are largely considering resection if appropriate, followed by radiosurgery. If resection is not appropriate, radiosurgery really is the mainstay. This topic in the middle is pretty debatable. A limited number of brain metastasis, 2 or greater. I put more than 10 here, depending on the institution and the practice patterns and the individual studies. And then finally, there still is a role for whole brain radiation therapy now given with hippocampal sparing approaches and memantine to improve neurocognitive sequela of whole brain radiation therapy. But a couple questions still remain. One is, what is the optimal number of lesions to treat in this setting of limited number of brain metastasis? And the other is, what is the optimal fractionation for these treatments? So what is fractionation and why is it important? Well, conventional radiation therapy is typically delivered in small fractions over the course of time to minimize damage to tumor surrounding tissues. And this is done in different dose levels based on the size of the lesion, which is typically inversely proportional. Hypofractionation used with radiosurgery, you'll see the depiction in the figure here, delivers high doses of radiation therapy to one lesion, but instead of over one session, over 2 to 5 sessions. And this will continue to improve tumor control, but really limit that damage to the surrounding tissues over time. And we all know that radiation therapy necrosis is a significant challenge for our patients with brain metastasis. So this brings us to our first study. This is by Meng and colleagues, prospective phase 2 trial of hypofractionated radiosurgery in patients with 1 to 10 brain metastasis arising from breast cancer. This was a prospective single-arm study, phase 2, that was conducted in Shanghai. And the goal of this study was to assess the efficacy and toxicity of fractionated radiosurgery, 8 gray per fraction in 3 to 5 fractions. The primary endpoint was intracranial local control with secondary endpoints of distant control in the brain, IPFS, OS, toxicity, and neurocognitive assessments. 173 patients were included, and you'll see here the large majority had HER2-positive disease, also 4 or fewer lesions, and the majority had lesions under 3 centimeters. So here are the results with follow-up of 15 months. The local control rates were quite good, 89% at 1 year, 77% at 2 years. But interestingly, a number that did decrease at 2 years was the distant intracranial control, the unirradiated brain, with a distant control rate at 2 years of only 27%. You'll see OS was 29 months, IPFS 11 months. And compared to historical control, where radiation therapy necrosis is around 15 to 20% in most series, radiation therapy necrosis was relatively low at 6.2%. So this abstract does show that fractionated radiosurgery does appear to be efficacious and safe. We really don't know what to do over 10 lesions and repeated radiosurgery over time. And then the other question is how to best integrate systemic therapies to help control distant control within the brain. So you'll see here the NCCN guidelines for systemic therapy options for patients with brain metastasis. And I elected to include all histologies here, melanoma, non-small cell lung cancer, and beyond, just to see how much progress has been made in this field over the past decade. I highlight, of course, the breast cancer choices, which are divided by HER2 positivity or HER2 negativity. And when we're selecting systemic therapies for breast cancer brain metastasis, we still do include a subtype-specific approach. We think about agents' characteristics as to whether or not they are brain permeable, as well as our patient considerations, their performance status, their organ function, and of course, their preferences. So one of the other questions is, are there genomic alterations in breast cancer brain metastasis that would help guide our choices? And that brings us to the next abstract by Dr. Griguolo and colleagues. This was an abstract that looked at 88 breast cancer brain metastasis tissues across 3 institutions, and each of these brain metastasis tissues underwent whole exome sequencing. The alterations were classified as actionable by the ESMO criteria you'll see in the box below. And on the right-hand side of the slide, you'll see that there were alterations in DNA damage repair pathways enriched in the triple-negative subtype, as well as alterations across the PI3 kinase P10 pathway, which was relatively well distributed across all of the subtypes. So when you think about the clinical applications for this work, I did want to draw your attention to a case series of 41 patients with breast cancer brain metastasis who were treated with a PARP inhibitor. This could have been at the physician's discretion from a germline mutation or a somatic mutation. This was a multi-center series led by our colleagues at Hopkins and showed a PARP inhibition duration of over a year for patients with breast cancer brain metastasis, so quite compelling. In addition, the authors also showed that if patients whose HER2-positive breast cancer brain metastasis harbored a PI3 kinase alteration, the outcome in survival was inferior. And there are several ongoing trials evaluating PI3 kinase inhibitors, brain-permeable PI3 kinase inhibitors in this space of breast cancer brain metastasis. One is ongoing at Dana-Farber, evaluating the GDC0084 PI3 kinase inhibitor with trastuzumab. And there's also a study through the Alliance looking at matching genomic alterations, including a PI3 kinase mTOR inhibitor arm, which is currently ongoing. So one of the other questions would be, what additional targets are seen in brain metastasis that could help guide our therapy? And this was a very nice retrospective cohort study that was conducted at the Duke Cancer Institute by one of my junior colleagues, Dr. Laura Older, who's a thoracic oncologist. And essentially what she did is she evaluated circulating tumor DNA from patients with metastatic breast cancer, as well as others. I'm just presenting the breast cancer cohort that had genomic mutations in a brain metastasis cohort versus a group with metastatic cancer without brain metastasis. So of those 150 patients, you'll see that the ESR1 mutation was enriched among the patients who had CNS disease at 60% compared to 25% amongst those who had metastatic disease but did not have CNS recurrence. And I think it's well known that the elacestrant is FDA approved for ESR1 mutant breast cancer. We also heard about imlunestrant earlier in this meeting. And we're awaiting the results of the Electra study, which is evaluating elacestrant with abemaciclib in this patient population. So this brings us to the next two abstracts. This is a phase 1 study evaluating a brain-permeable SERD, SIM0270, in patients with hormone receptor positive, HER2 negative breast cancer. This is a brain-penetrant, highly potent oral SERD. You'll see in this phase 1 study, MTD, the recommended phase 2 dosing, was established at 60 milligrams daily of a 28-day cycle. In the dose escalation cohort, only one patient of the 51 had brain metastasis. So this is more about the experience with the compound as opposed to actual activity in the brain. Approximately a quarter of the patients tumors harbored a ESR1 mutation. The PFS across the whole cohort was 5.5 months, and interestingly, a little lower in the ESR1 mutant population at 3.7 months. Here's the activity of the monotherapy. The clinical benefit rate was at 24 weeks was 37.8%. And interestingly, one of the unique treatment-related events here was bradycardia in about half of the patients, grade 1 to 2, with only one being a grade 3. So interesting nonetheless. For this particular compound, there's an ongoing, almost accrued, I learned at the poster session, for a brain metastasis-specific cohort. Hopefully we'll learn about that soon. And now we're going to review the combination data with everolimus, which was the second poster presented by Dr. Zhang and colleagues. So again, this was a phase 1 dose escalation of the oral SERD, SIM0270, in combination with everolimus. The MTD was established at the 60 milligrams monotherapy dose, along with everolimus at 10 milligrams, which is the maximum dose. Here there were 2 patients out of 8 with a DLT. And again, we did see the bradycardia in about half of patients. You'll see here the waterfall plot for the efficacy with a confirmed overall response rate of 16% across the whole cohort. And amongst these patients, 4 patients did have breast cancer brain metastasis. Interestingly, 2 of those patients, so 50%, albeit small numbers, had a complete response in the brain as measured by RANO-BM. PFS was 8.2 months. So we look forward to the next phase of development with this compound in the brain metastasis specific cohort. And there's also a randomized phase 3 that will be looking at SIM0270 with everolimus versus physician's choice with results anticipated. So moving on to the last abstract by my co-presenter, Dr. Brenner and colleagues. This is a novel class of therapies for patients with brain metastasis, and the focus of this particular abstract was the challenge of leptomeningeal disease. This is radiopharmaceuticals, specifically a rhenium nanoliposome. This is a next generation encapsulated liposomal nanoparticle encapsulating rhenium, which is a beta-emitting radionucleotide with a half-life of 90 hours and a 2-millimeter tissue path length. In preclinical studies, there's been high CSF and cortical exposure, but again, sparing the radiosensitive white matter to help with longer-term sequelae of therapy. This treatment is administered intraventricular through an Ommaya reservoir. So Dr. Brenner and colleagues presented the RESPECT-LM phase 1 study of the rhenium nanoliposome in a standard 3+3 design. 33 patients were screened, 20 were evaluable. Around half of the patients in this study had breast cancer across all of our subtypes. There was a single DLT at the 66 millicurie dosing, which was thrombocytopenia. And what's really interesting is you can see the distribution of the rhenium nanoliposome at the 45-minute post-administration, the 24-hour post-administration, and even out to 7 days post-infusion. And in terms of the tissue exposure, you saw a dose-dependent increase in gray into the 100s, whereas the normal tissue, such as liver and spleen, had very low exposure at 3 gray or less. So very exciting data here. Here's the efficacy overview. Around 75% of the patients had a clinical benefit by MRI. That was also sustained in the breast cancer cohort, 6 of the 8 patients. There was also a % change in tumor CSF after a single dose of the rhenium nanoliposome. The median overall survival was 9 months, which compares favorably to historical control, and 2 of the 9 patients with breast cancer were living out after 600 days. So in conclusion, I think we are seeing many options beyond what we currently have in 2024. I think there's a very bright future ahead here. We're seeing steady progress in the development of strategies for our patients with breast cancer, brain metastasis, as well as leptomeningeal disease. We're seeing refinement in radiosurgery strategies, further dissection of brain metastasis biology, expansion of systemic therapy choices, and hopefully in the future we'll see our oral SERDs, our PARP inhibitors, our PI3 kinase inhibitors, and radiopharmaceuticals listed in our NCCN guidelines. So with that, I thank you for your attention this morning, for attending so early, and I look forward to the discussion with the co-authors. Thank you.
So you may not have noticed, but we're an intimate crowd this morning. And that said, we do have Slido, you know, the way of entering questions that I can see up here on the screen. So I encourage you to do that. But you can also come up to the mic. You could probably sit from your chair. There's nobody here in the back. So feel free to use the mics if you have questions. Don't be bashful. So I want to start out and, you know, just ask Dr. Brenner, the rhenium compound, obviously this was proof of principle, showed it works, you can give it, it has activity. Is this a strategy that can be repeated more than once? I mean, obviously the trial wasn't designed to look at that question, but.
Yeah, that's a great question. Hopefully this mic's on. We actually are in the process of doing a multi-dose. So if you look at other radiotherapeutics like lutetium dotatate and lutetium PSMA and even radioactive iodine that they're given in multiple doses, lutetium dotatate is given usually 4 doses. So and we, based on our experience treating patients with multiple doses in a compassionate setting where we patients who have responded went back and got additional doses, we did submit a multi-dose protocol to the FDA, which we're expecting to open within the next couple months, and that will allow patients to be treated at 56-day intervals, and that's okay, 28 intervals, and then after that, 14-day intervals. With the plan is 3 doses for the first 3 cohorts, and if that's well tolerated, then we'll go up to 6 doses.
So would you anticipate, just thinking it through, even though you haven't gotten the data yet, that there would be any sort of cumulative sort of toxicity that you could anticipate potentially?
So interestingly, we didn't really see any CNS toxicity. Now these patients, a lot of them have been followed for well beyond a year, and there was no evidence of any CNS injury. All the toxicity we saw seemed to be acute and was really related to systemic doses. So that's really what you see with other radiopharmaceuticals. For example, lutetium dotatate, the issue is that you see kidney absorbed doses, and so you can only get about a 2 to 3 to 1 ratio of exposure to the tumor relative to the kidney. In our case, we see blood absorbed doses around 3 gray, which is what prior studies have suggested is probably where you're going to start to see some cytopenias. And coincidentally, the patient that had the grade 3, grade 4 thrombocytopenia was one of the patients who had above 3 gray in the blood, suggesting that that probably is the issue. So we're not going to try and push it anymore in terms of single doses, but with our multi-doses, we did take it down to our cohort 3 dose. And so we think that it'll be well tolerated, and we think we can give it together with systemic therapy at that dose.
Great. So I want to pose a question to Dr. Zhang, and then, for the panel as well. Your data with the compound was, optimistically saying that, we're going to have data on the brain, and we saw data from a couple of patients that it worked very well in the brain. But ER-positive breast cancer isn't the most common subset of breast cancer that goes to the brain, but in those situations where you do have brain mets and systemic disease, in the absence of this compound being available, if you look at the NCCN guidelines, there's not really an ER-positive little slot for how we treat these patients. So how do you think about that today? Because this compound isn't available yet. How do you treat ER-positive brain mets that maybe you're not using radiation or a radionuclide for?
Okay. If this drug is not available, I think elections maybe also is available now. So you just talk about election study and other study found that maybe the CSF concentration is higher than in the blood. So brain metastasis maybe could be controlled by this oral SERD. And actually, for our oral SERD in the rat model, we found that the concentration of the blood, concentration of the brain is 3 times of the concentration of the blood. And for the dog model is almost 15 times. And we tested one patient with brain metastasis. We found the concentration in the CNSF is 3 times of the blood concentration. That means almost 9 times of brain of the concentration in the blood. So I think oral SERD, most of the oral SERD have the brain penetrate, but our oral SERD is, I think, one of the best. However, if we do not have the chance to use elastrant or our oral SERD, SIS showed that for the oligometastasis, we choose first. And if this is a lot of metastasis in brain cancer, brain metastasis, I think the whole brain is okay. However, we for ER-positive HER2 low patients, we know that TDXD is also a good option. We found that about 40% of the patients have PR, or one of the half the patients could get a DCR of the patients have the brain metastasis control, and we also have the CHOP2 ADC and others. So I think if we don't have the this oral SERD, we can use ADCs. We can use some that can penetrate the membrane, the chemotherapy. We can use some endocrine plus abemaciclib and others.
Carey, you have anything to add to that? Yeah.
No, absolutely, and I think it is interesting. I think many of us use the CDK4/6 inhibitors in the setting of ER-positive breast cancer brain metastasis, notably abemaciclib, based on the JPBO study, almost a decade ago. But it's actually not listed in the NCCN guidelines. So, I think I'm hopeful that, these will be listed. I think we're using them in clinical care in this setting.
So where you're not using radiation therapy, if there's a situation where radiation isn't going to be part of the plan, and it is ER-positive disease, would you try to leverage HER2 low and preferentially use TDXD?
An ADC? I think in the ER-positive space, I would say I typically would be leaning toward radiosurgery followed by a systemic therapy. I think in the setting of HER2-positive disease, where the intracranial responses to TDXD are so robust, in most series 70% or more, there are certainly strategies and even clinical trials in the planning phases trying to determine, do we really need radiosurgery before an intracranial response rate of 70%? I think the argument there is that, the response rate to radiosurgery is about 90%, so it's hard to get better than that. So, I think it really depends on the setting, the size of the lesions, but I just don't have as much faith, I guess, in the intracranial response rates in that setting.
Another question for Dr. Brenner, and just if you could highlight some of the eligibility criteria for your study and whether positive CSS cytology was required.
So we did require that they had either radiographic or positive cytology, but both were not required. We were using the CNSide assay, which is a microfluidic assay, which has a much higher sensitivity than standard cytology. A matter of fact, we only had one patient out of all of them that did not have a positive CNSide. So we feel that that is, if there's radiographic involvement but absence of cytology, looking at the ESMO guidelines, it seems to be appropriate to include those. So we did allow patients with radiographic disease with negative cytology, but then again, they were still quantifiable by CNSide in almost all the cases.
Great. So I had a question for Dr. Griguolo. So really nice work on the genomics. And I think when we send next generation sequencing or ctDNA, we're always hopeful to find a somatic BRCA mutation. And I'm curious if amongst your patients tumors where a BRCA alteration was seen or PALB2 alteration was seen, do you know if germline was also present?
Thank you very much for this question. We obviously tried to look into that data, but unfortunately we do not have the data regarding the germline status for all the patients. We had at least one patient for which this was clearly a somatic mutation, as the germline was tested and it was negative. And nevertheless, I want to highlight that there was some data from the Dana-Farber group looking into the risk of developing brain metastases for patients, carriers of BRCA1, BRCA2 mutations, and they actually saw that especially in the hormone receptor positive, HER2 negative breast cancer patients, there seemed to be an additional risk of developing brain metastases, especially for the BRCA1, BRCA2 carriers. So there might also be some of these patients which are actually germline carriers and which then develop brain metastasis. Nevertheless, there probably also is the additional some additional somatic mutations which are only present in the brain mets.
Any other questions from the audience? Okay.
Good on time.
We're right on time, so we're going to keep on going. I want to thank the panel. And if we can have the next panel come up.
That's great.
And to discuss the next set of posters that were displayed in the back, Dr. Brenner will be taking us through them.
Can you? All those wonderful images might be taking a long time to load.
Can you bring up Dr. Brenner's slide set, please?
There we go.
All right.
All right. So Thank you for the opportunity to discuss these posters. We're going to be discussing posters 6 through 10, which fall under the topic of translational therapeutics for brain metastases. Here are my disclosures. So to put these into perspective a little bit, I think Dr. Anders did a great job in terms of discussing the overall challenges that we have with dealing with brain metastases and where we are with new therapies entering the fold. But in terms of immune responses, they probably haven't been as robust as we would like in the brain. And there have been a lot of comparative analysis over the years to suggest that the immune features may systematically vary according to sites of metastases. If you look at the Aurora data set that was presented back in 2023, they compared the primary site of disease with the metastatic sites of disease, specifically looking at the immune signature on expression. And they found that there was some differences. If you look at lung, it was very much similar in terms of the immune signature compared to the primary site. But when they looked at liver and brain, there was a significant downregulation in immune genes in those sites of disease, suggesting that there's something specific to the site of disease that affects the immune response or the ability for an immune response. Similarly, when we look at tumor-infiltrating lymphocytes, we see that they can vary by site. In the Yale data set that's there in the middle, you can see that when they looked at the primary tumors in breast cancer, they saw that the number of TILs was pretty robust overall. But then when you looked at sites of metastases, the number of TILs was dramatically lower. So the primary site had abundant TILs, but really negligible in the sites of metastatic disease. And then when you look at the Japanese data set, this was a multi-institutional effort in Japan where they looked at a number of matched both primary and brain metastases. And again, the number of TILs was dramatically lower in brain metastases than in primary brain tumors. So it leads to the question is the brain environment significantly different? Do we see different gene signatures in the brain than we do in other sites of disease for breast cancer, and how to explain these discordant immune response results? So the first poster we'll discuss is the Thulin et al., which is gene expression profiling of brain metastases and matched primary breast tumors with focus on the immune system and tumor microenvironment. And so I'd like to focus on first the gene expression signatures. And so you can see that immune signatures were really abundant in terms of being different between the primary and the brain metastases. In particular, we see a loss of both Treg and CD8 signatures in the brain metastases compared to the primary. And when you look by immunohistochemistry, or when they looked by immunohistochemistry at the CD8 positive and CD4 positive T cells, they saw that both of these were significantly lower in the brain metastases as compared to the primary site. And overall, you can see on the gene expression, the GSEA analysis, that there was a loss of anti-tumor immune activity in the brain metastases. Which was not made by the authors, but I did want to point out that they do show that there is a higher level of hypoxia-regulated genes in the brain metastases, and as well as there is a increase in SOX2. And so we know that from primary brain tumor researchers that there is significantly high hypoxia in primary brain tumors, which is felt to be immunosuppressive. SOX2 is one of these hypoxia-regulated transcriptional factors that has been known to show a immunosuppressive effect. So just a potential mechanism of action, but we need to know more about why the brain seems to have overall a lower immune signature. But their conclusion was downregulation of gene expression signatures related to the immune system and tumor microenvironment in brain metastases, and that might account for the reduced effect of immunotherapy. The next poster, Cabraggi et al., looked at spatial transcriptomics of matched breast cancer brain metastases in primary tumors. And so in this case, they did a little bit. Usually when I think of spatial transcriptomics, we think about barcoding and looking at the individual cells and where they are. In this case, what they did is they did immunohistochemistry staining for cytokeratins to identify tumor and for CD45 to identify the immune component, and they identified these areas of interest. And they looked at the expression within those areas of interest. And you can see the overall representation in the data set there, mostly hormone receptor positive. And so let's just kind of focus on the cell component of their analysis. And you can see there on the right is breast. And so breast, you see a lot of green. Well, the green is the T cells. And so it was a lot more T cell representation in the breast primaries than there were in the brain metastases. We saw that also on the last poster as well. But on top of that, you see that there are more macrophages in the brain metastases and more endothelial cells. And that quantified statistically significant, as you can see there in B, lower CD8 positive T cells in the brain metastases, higher endothelial cells, and higher macrophages in the brain metastases. And just to bring up a prior analysis, such as this one, which was done with either immune checkpoint inhibitors or chemotherapy, looking at the immune component in terms of cellular components of the resected lesions after neoadjuvant chemotherapy. And you see that associated with residual disease is endothelial cells, and M2 macrophage is kind of a little bit in the middle, but basically, suggesting that if you have an abundance of endothelial cells there, that's probably going to be a relatively non-responsive tumor. And that might be, again, related to hypoxia. I'm just to speculate, because we know that we see abundant endothelial hyperplasia as a response to hypoxia. And so it might be another marker of hypoxia. Then they looked further at the gene expression signatures, comparing the areas of immune-rich versus tumor-rich. And basically, one thing that was in common between the two is you do see that there's a immune overall increased expression signature, both in the primary brain tumor and the primary site. So that wasn't really changed. But one thing that was significantly different is you look in the bottom there, that the immune-rich favored an increased estrogen expression signature in the primary brain. So as opposed to what you would think it would be in the primary tumor site that you would see in the tumor microenvironment, you see an increased estrogen expression signature. No, it was actually in the immune environment, primarily in the immune enriched component. So they basically concluded that they identified estrogen receptor signaling as a pathway that was differentially expressed in breast cancer brain metastases compared to primary tumors, triple-negative breast cancer. And of course, it's a small number, but certainly is hypothesis generating, and why you see increased estrogen signaling in the immune component in triple-negative breast cancers, primarily in the brain, is something that needs to be considered. Maybe related to estrogen receptor beta or suppressive, but you see proliferation there, so a little bit hard to basically put a mechanism behind that. And then the next poster we're going to discuss is 1408, which is from Hewitt et al., where they were targeting the CXCL1, CXCR2 axis to block brain metastases in inflammatory breast cancer. And this is based on the fact that E-cadherin is overexpressed in inflammatory breast cancer and oncogenic and inflammatory breast cancer tumor models. They see that soluble E-cadherin, which is a proteolytic fragment of the full-length E-cadherin, is associated with poor overall survival in inflammatory breast cancer patients, as you can see there in A. But on top of that, they have a higher incidence of brain metastases with higher soluble E-cadherin. And that persisted on multivariate Cox regression analysis. So based on this, they hypothesized that soluble E-cadherin might drive brain metastases in inflammatory breast cancer. And so they used animal models to try and look at this further. They overexpressed soluble E-cadherin in 2 different inflammatory breast cancer models and looked at those animals after intracardiac injection of those cell lines to see the number of brain metastases. And the number of brain metastases was significantly increased in those that overexpressed soluble E-cadherin. On top of that, the area of brain metastases was also increased. Overall survival was decreased in those animals, but particularly the brain's metastases-specific survival was decreased. They went back and they looked at soluble E-cadherin's effect on astrocytes, because we know of this interplay between astrocytes and brain metastases. They saw that GFAP was increased, and GFAP is a marker of reactive astrocytosis, usually in response to injury. So it looked like soluble E-cadherin was increasing the amount of astrocytosis in these cells. So again, we know that there's a significant interplay between astrocytes and cancer cells in the brain. It involves a number of different things, but particularly there is some data suggesting that this interplay is involved in helping the cells cross the blood-brain barrier. A number of different cytokines have been suggested to be involved, but of those, as you can see there in the bottom corner, CXCL1, IL-8 has been considered one of those, and it has an obligate receptor of CXCR2. When they took the serum and applied it onto the cancer cells, when they were doing soluble E-cadherin and looked at the media, there was a significant induction of CXCL1 from those cells, from the soluble E-cadherin. And then when you apply that conditioned media from the soluble E-cadherin expressing cells onto astrocytes, you see an induction of CXCR2. So in order to further evaluate this, they went on to inoculate mice, and prior to inoculation in one model, they treated them with an inhibitor of CXCR2. And then in the other model, they allowed the tumors to establish and then treated later with an inhibitor of CXCR2. And what they saw is when you treat prior to inoculating the tumor cells, you see an improvement in overall survival that's statistically significant, but a significant difference in terms of brain metastases-free survival. And you don't see the same level of benefit in those animals that were treated later after establishment of tumors. Survival was not statistically significant, and the degree of brain metastases-free survival was somewhat less. So their conclusion is that higher serum ECAD levels independently predicts poor OS in inflammatory breast cancer patients, but as ECAD may promote brain metastases through NF-kappa B signaling that drives reactive astrocytosis in the brain microenvironment via CXCL1, CXCR2 axis, and that soluble ECAD and CXCR2 might be potential therapeutic targets for metastatic inflammatory breast cancer. The next poster we're going to discuss is a little bit of a shift from the prior two, and this is central nervous system is the primary site of first relapse in patients with triple-negative breast cancer, achieving a pathologic complete response after neoadjuvant chemotherapy. This was a retrospective multi-center study of over 1,000 patients with triple-negative breast cancer diagnosed from 2001 to 2023, looking at PCR versus residual disease. And not as unexpected, you see in patients who have a residual disease after neoadjuvant chemotherapy that they have a higher rate of distant metastases at 26% versus 5% in those patients with PCR, and also visceral metastases versus in residual disease versus PCR. But here's some real meat and potatoes of their findings. If you look at residual disease patients and their sites of metastases and compare that to those with pathologic complete response, there's some notable differences. First of all, in the visceral disease, you see a higher rate of lung and bone involvement. You see less in those patients with PCR, but what you really see in those patients who have had a PCR in terms of when they develop metastatic disease is CNS. 60% of these patients who had a PCR developed CNS as a site of visceral disease, which is threefold higher than those patients with residual disease. So their conclusions is that in patients who are achieving a PCR after neoadjuvant chemotherapy, CNS-only relapse is the predominant site of first recurrence. And so something to think about. I think in terms of thinking about this, if you have responsive disease, you're going to have responsive disease where the therapy is able to have bioavailability. If there's a lack of bioavailability in the CNS, then unfortunately that's going to be a site of relapse. So then our last poster is from Harbeck et al. With effects of trastuzumab deruxtecan on health-related quality of life and neurological function in patients with HER2-positive advanced metastatic disease with or without brain metastases from DESTINY-Breast12. I think we're all been very excited about the findings from DESTINY-Breast12. It was a single-arm phase 3b/4 of TDXD and showed a 61% 12-month progression-free survival in patients with brain metastases and a CNS overall response rate of 72%. So in this study, they had patients both with brain metastases and with no baseline brain metastases, and they're relatively even. They assessed the health-related quality of life using ERCCS-C30 and nanoscale in the brain metastases patients, as well as in the non-brain metastases baseline patients. And here's just a quick look. I put the baseline brain metastases on top and then the no baseline brain metastases on the bottom. And there's a couple things that are really salient points here. Number one, we're always worried about cognitive function in our patients with brain metastases. And we see that the cognitive function was well preserved in these patients with brain metastases when you compare it to the no baseline brain metastases. And overall, the estimated deterioration of 12 months were greater than 50% for cognitive, emotional, physical, and social functioning and pain scores for those patients with baseline brain metastases. So reassuring that TDXD preventing progression prevents decrement in quality of life in our brain metastases patients. And then nanoscale, basically physician-assessed physical exam findings in terms of neurological stability. And we see again on the top the patient with baseline brain metastases and on bottom patients with no baseline brain metastases. And what we see is basically relatively similar, a little bit worse in the baseline brain metastases, but neurologic stability was preserved for the majority of patients, 86.6% of patients, and that was throughout the study out to 55% through treatment. So our patients are doing well on this regimen and a regimen that seems to have activity. So conclusions for these are, number one, the immune microenvironment in breast cancer brain metastases remains suppressed relative to other organ sites with fewer T cells and overall lower immune signature. A lot of different potential components there in terms of at play, whether it's hypoxia, the abundant amount of macrophages that we see there, or just simply the cytokines being presented in the brain relative to other places. Estrogen response signature can be seen elevated in immune cell infiltrates from triple-negative breast cancer brain metastases. And in inflammatory breast cancer, soluble E-cadherin can drive CXCL1, CXCR2 feedback loop between tumor cells and astrocytes, and blocking CXCR2 may block breast cancer brain metastases establishments. And when patients with PCR develop distant mets, it's dominantly CNS as a first site of metastatic disease, and health-related quality of life is preserved in patients with breast cancer brain metastases on TDXD.
All right, again, just to emphasize, if you have any questions, feel free to go online or don't be bashful about going to the mic. So with that said, I just wanted to ask more or less the panel, one of the themes that comes out of this is that in the brain, it's a microenvironment that's, basically suppresses the immune response. Are there any strategies, even if they're aspirational, that you can alter that microenvironment to make it less friendly, in a sense, to metastases without having other detrimental effects?
I think there's a significant interest in certainly reducing the immunosuppressive cell population, such as macrophages and M2. And there are a number of different therapeutics that have been evaluated in terms of that. And so we'll see if any of these come to fruition. The other thing is trying to drive up the PD-1 expression despite this microenvironment. And we do see that in those responses that we see that develop a PCR that have a relatively macrophage-rich environment, when they have abundant PD-1 and PD-1 inhibitors do work, that you do see a loss of that macrophage population. So I think it's a combination both of driving up the T cell response as well as driving down the infiltrating immunosuppressive cell environment.
Dr. Thulin, you have any comments?
Yeah, I mean, in our study, I think shows that a current treatments are unable to eradicate potential cells in the brain as patients with a PCR and residual disease. So apparently sensible to treatment do not respond in the brain, and they have the same cumulative incidence of brain-only relapses. And also the addition of immunotherapy in Keynote 522 didn't change the overall rate of CNS involvement, which we saw in our study, which is made largely of patients treated with only chemotherapy. So the current treatments which we had available and have available now are not able to fix this challenge due to the data we saw today, which the microenvironment is highly immunosuppressive. So I don't have a future plan, but the current treatments we have are not able to fix this.
Anybody else? Yes, go ahead.
Do you want to go first? You go.
Yes, Nadia.
So, I mean, I thought the data were rather frightening on the poster with the PCR. It's almost like the brain is a sanctuary for those tumor cells. We are very good at killing them outside everywhere, but then they sort of get there and cause brain metastasis. I think next year will be crucial, because when we report, the colleagues, I'm not part of the investigators, report out the Destiny Breast 05, we'll see whether we can actually prevent brain metastasis by TDXD. And that would be a good step forward, because then we can analyze why this agent is able to prevent while others have failed. Like, I mean, the Catherine study, we also have half of the patients have brain mets in the distant recurrences at first sight in the TDM1 arm. So TDM1 certainly doesn't prevent brain mets, but if TDXD were able to, I think we can take that and then build on that and see how we can effectively prevent this from happening. And the nice thing about the TDXD is that it's also applicable to other entities outside of the HER2-positive setting. So I'm still optimistic, but I'm very, very interested in seeing those data, and think that's going to help us a lot, because, I mean, patients with a PCR having brain mets as the first site of metastasis, when we tell them in the clinic you're likely to be cured, I think is something that is very difficult.
Yeah, so I totally agree, and I think it was very interesting to see this work on patients increasingly being diagnosed with brain metastases as the first site, because we also see that the T cell population is exhausted in the metastatic setting in general, I don't believe, I'm hopeful for new drugs that target macrophages, but I do believe also that in the adjuvant setting, increasingly we should include endpoints such as time to CNS involvement in order to study that these drugs actually prevent brain metastases, because that would actually be of the best benefit to our patients.
So just one additional comment to the PathCR presentation. You know, I think this is not specific to triple-negative breast cancer. And we have Dr. Hubbard here, who did really nice work in the HER2-positive population, which also shows this phenomenon that PathCR is not necessarily predictive of decreased risk of CNS metastasis. So I think, you know, one way for us to think about this as a community is go back to those primary tumors, determine which ones have PathCR, which ones recur in the CNS, and which ones don't, and really interrogate those from the primary site to understand which ones might end up recurring in the CNS. So I agree with you, Dr. Harbeck. It's a little hard to see that data, but I also see this in our clinic, right? Many patients who come to us after a PathCR, they're reassured, and then they have the CNS recurrence as a sanctuary site. So I think it does not appear to be subtype specific, and it's very interesting and concerning that we're seeing it across now 2 subtypes.
I think we need to know a little bit more about the frequency, so we can also adjust our surveillance, because we would never do proactive surveillance in those patients unless they come with symptoms. And if we had a little bit better idea who would be at risk, we could sort of tailor the surveillance a little.
And I think, just one more comment, I think it's also important to keep in mind the time interval and where we are today versus where we were several years ago. And I think we now have more CNS active agents. And so as we're using those in the metastatic setting or even in the adjuvant or neoadjuvant setting, they might help prevent this phenomenon to begin with. So.
Question at the mic.
Thank you. I would like to congratulate all the speakers and the posters. It was a great session. So my question is more open question. Do you know how early this immune suppressive microenvironment is generated in the brain? Like, does it develop a pre-metastatic stage? And can it be predicted with biomarkers or something like that?
Anyone want to comment on that?
I just like in IBC, so far we don't have clearly molecular marker, biomarkers, so I have no answer this time. Yeah, I don't know like other type breast cancer if they have molecular biomarker can help, but IBC so far we don't have. Yeah.
And do you see changes before the tumor cells make it to the brain?
Yeah, it's a hard question. Yeah, to me it's a hard question because I'm working mainly like preclinical some work. So it's like, to me, this is a hard question. Yeah.
So I guess one question, just to carry on with that, the brain it has an inhibitory environment to begin with. I guess the question is it enhanced in the presence of malignant cells? Is it more so? Because we know at baseline it is, right? Is that correct?
Well, I mean, Carey, you probably know this much better, right? But I mean, isn't it true that the cancer cells first cause inflammation in order to invade, and then following that, inflammation doesn't seem to be as needed, and then inflammation goes down?
Certainly, and I think your question is a really good one, is, sort of what's happening in the pre-metastatic niche versus what we've largely studied, which is once the CNS metastases are established, which, consistently we're seeing it's an immunosuppressed state. And it's really interesting to see the macrophage population sort of also consistently rising up. I think it would really require experiments going back and looking at, in a mouse model, what's happening, and, you do the intracardiac injection, evaluate the, the immunosuppressive state of the brain prior to metastasis, and then throughout the course of early and then late. It would be a really interesting experiment if anyone wants to take that on. But in general, I think it is an immunosuppressive state. And I think the other thing that's really interesting is once the cells are there, they many times start to take on neuronal processes, right? We've seen data from some of our colleagues that they start to shift their metabolism to the GABA shunt, right? They're not using normal processes. So how can we prevent that as well?
I'd add one thing. There have been some preclinical experiments where they implant in the memory fat pad and then later resect it and then do intracardiac injection. And by implanting in the memory fat pad and then removing it, those animals are more susceptible to brain metastases, suggesting that the primary tumor can prime the brain. And so there's some work ongoing in terms of identifying those factors. The other thing is as was mentioned in that poster, that the astrocytes do play an important part in terms of establishing the microenvironment for the brain metastases. There's two parts to that. One of them is helping those tumor cells get underneath the endothelial cell and across the basement membrane. And that is an active interplay between the tumor cells, the astrocytes, and the microglia. But then once they get there, they do tend to feed off of each other, just like in bone or many other sites.
All right, so I want to thank the audience for being here. I want to particularly thank the panelists and the discussants for a robust discussion, and enjoy the remainder of the meeting. Thanks so much.